Hello and good evening. Today we're going to be talking about SGM population demographics and population health, an intersectional social epidemiological overview. This is for week 1 of LGBTQ health, the summer quarter of 2023 for Northwestern University's Feinberg School of Medicine program of public health. So first things first, why do we need to collect SGM data? Or better yet, why do we need to collect data on sex, sexual orientation, and gender identity? Well, first of all, this data collection aligns with high public health priorities, including with the Healthy People 2020 goals. The Healthy People notes that excluding questions that capture sex, gender, and sexual orientation would perpetuate a lack of knowledge about the health of sexual and gender minority populations, or LGBTQIA+ populations, because these are the questions that we would ask to understand how to discern who LGBTQIA+ people are within data sets. It's also really important to center that data are therefore powerful because they let us monitor population health trends that let us see where we are experiencing health disparities or health equity for minoritized populations, in the context of sex, sexual orientation, and gender identity. That lets us look again at LGBTQIA+ people and our health. So on that note, it's really important to center that data are people. In quantitative population health studies, each row of data represents a person's life. I cannot emphasize how important that is, that data are more than numbers, they are people. It's really often hard to center this in quantitative data because we do actually, when we're running analyses and we are looking at numbers, qualitative methods in contrast really make centering people's stories and people's identities a little bit easier, I think, because you aren't looking at numbers, you're looking at text. And it's really important to remember, though, that ultimately what we're doing when we have meaning making, that we are pursuing an empirical research, is trying to assign stories to numbers and trying to generalize from stories to the health of populations. And so it's really important when you are conducting health equity research that you focus on understanding and centering that that's what you're doing, that's the pursuit that you have, because it's not just that one row of data is one voice, it's that when we collect the many people's stories, then what we're starting to do is make meaning that might implicate the health of communities. And again, as we'll discuss in a variety of lectures this week and the next, as well as really throughout the course, social power systems and stigma in particular is a fundamental social determinant of health, shape community health. And so it's important that you don't flatten data and to be nothing but numbers, and instead we center stories and social power and take a critical view when we're thinking about how to interpret findings about LGBTQIA+ health. So a bit more about LGBTQIA+ populations. I really wanted to go through what the data have been able to tell us so far about population size and demographics, because I do think it provides an important context for public health and health equity to understand what we're talking about and try to center in what we know so far on these topics. So first of all, the Gallup Polling Institute has found in 2022 that bisexual identity, 7.2%, and also gender identity, they mix these up in their question, that 7.2% of adults identify as LGBT. The National Survey of Family Growth has found that 8.2% of adults report same-sex sexual behavior in their lifetimes, although the sex breakdown of this is a little bit unequal. And that we also find that from that same survey that 11% of adults report same-sex attraction. It's important, of course, to highlight that these numbers and percentages vary at the intersections of race and ethnicity, and I specifically wanted to focus in today on LGBT, American Indian, Alaska Native populations. What you can see is that the Williams Institute has conducted a study that found that approximately 285,000 individuals who are both LGBT and American Indian, Alaska Native are living in the United States today. And that if you break that down, that's 161,000 LGBT American Indian Alaskan only adults in terms of if you're using the race ethnicity categories from the US Census, and 124,000 LGBT American Indian Alaskan Native adults who also report at least one other race ethnicity. And you can see the breakdown here according to the census region about where folks are living in the United States as a colonial nation. So what a bit more, turning back to Gallup data. Gallup data has shown over the past decade that US LGBT identity is increasing. If you look over the last 10 years, it's doubled, approximately speaking. It's important also to understand the trends in LGBT subpopulation within the Gallup data if you look by age cohort as well. So what you can see here on the rows is LGBT and other LGBT in terms of the subpopulation identities within LGBT communities. And then on the columns, we have the age cohort or generational cohort. And what you can see here is that, especially for Gen Z, millennials, and Generation Xers, that bisexuals comprise the largest sexual minority subpopulation. You can also see that for transgender people, which of course this is not a sexual orientation, this is a gender modality, that you find that among younger generations that more adults are reporting that they are transgender, and that this is roughly consistent from Gen Z to Gen X. Then you start to look at baby boomers and the silent generation. However, the single largest sexual minority category would be gay individuals, then followed by bisexual individuals. And although in baby boomers, lesbian and bisexual individuals are tied. And then the silent generation and baby boomers have a little bit lower percentage of people who say they are transgender. And interestingly, the silent generation, as well as Gen Z, have the higher percentage of people who report an other LGBT identity. So if you go to the most recent update that I could find from the Gallup data that looks at the intersections of sex and race, you can see how that has varied from 2012 to 2017. One thing I want to point out is that by binary sex that Gallup captured, that more female than male individuals report an LGBT identity, and that gap seems to be increasing from 2012 through 2017. And then if you look at by race ethnicity, that white non-Hispanic individuals are often the least likely to identify as LGBT across the years than people who are Black non-Hispanic, Hispanic, or Asian non-Hispanic. So really, I want to center in that who is LGBT? It seems to be that within the data that people who are female and people who are Black, Hispanic, and Asian are going to report the highest percentages, most likely, of being LGBT. And it's important to think through, as we talk through more in the course, an intersectional lens to understand the impact that this might have on the health of LGBT populations. So here is a map that shows the percentage of US adults who are American Indian, Alaskan, and Native and identify as LGBT. So this kind of speaks back to the slide I showed a little bit earlier. The number of adults who identify as transgender, this estimate varies a lot, and as I showed, it varies significantly by age cohort or generational cohort. But overall, the Williams Institute has estimated, based on behavioral risk factor surveillance system data, that about 1.4 million Americans, or 0.6% of all US adults overall, would identify as transgender. The Williams Institute has also issued a separate report indicating that there are 1.2 million LGBTQ adults in the United States who are non-binary. And if you look here at the breakdown, you can see that gender identity among non-binary LGBTQ adults would be 42% say that they are transgender, 39% say that they're lesbian, bisexual, or queer cisgender women, 19% say that they're gay or bisexual, queer, cisgender men. And then if you look at the age breakdown urbanicity, racial breakdown, and whether people were born in the US. You can see those numbers here. It's interesting. I'm not sure. I need to look more into this to see if the non-binary respondents said that they were cisgender or simply said that they were not transgender. In my experience conducting scientific research in demographic questions like this, you would not find many people saying that they are cisgender when they're saying that they're non-binary, although some may still do so. Instead, it's more likely that individuals will say, well, I'm not transgender, or I'm not sure if I'm transgender, than to say that they are both non-binary and cisgender. Food for thought. All right. And if you look within the sexual orientation breakdown for adults who are non-binary, this is what you see. So you see a large percentage, the largest percentage saying that they are queer, followed by bisexual, followed by asexual spectrum, and then gay, lesbian, and then, bisexual and pansexual are both equal following queer. But in terms of the most common sexual identities in non-binary LGBTQ adults. But what I want to call out here is that many of the non-binary people don't hold a binary sexual identity category. And so I think that there's often a misunderstanding that just based on the lexicon of saying bisexual, that a person would not be non-binary. But instead, I would urge people to view bisexuality much as pansexuality, or even sometimes queerness, alongside being a sexual orientation category that itself transcends a binary of gay and straight. And so I think in some ways it's not surprising to see sexual orientations that transcend a monosexual set of identities within a non-binary gender identity. It certainly reflects my own story, although of course there are many stories besides my own. Okay, in terms of asexuality, this is an area where there is lesser research that can be talked about from a demographic point of view that's representative probability studies, because oftentimes questions do not include a structured asexual response option. If they, in terms of demographic surveys about sexual orientation, if there is, and often there's times we only would see a sexual identity question, not a sexual attraction or behavior question in many different demographic surveys or health surveys. And so there was a highly unusual nationally representative probability study that was conducted back years ago in the United Kingdom, and it was published by Bogart in 2004. And what his research found is that about 1% of people in the UK reported no sexual attraction to males or females. And so this gets at that 1% number of maybe of people are asexual. But of course, if you look at many questions as they're being structured now, like I said, they don't have any sexual response options. So the UK's census question for sexual orientation had a write-in option. And what was found was that about 0.06% of people wrote in asexual as their sexual orientation when asexual was not offered as a structured response option. However, I would say that this is a highly flawed method of trying to capture information about what percentage of the population might identify as asexual. You know, and there's much more work that's needed to develop validated, reliable measures to understand what percentage of population might be asexual in the general population. Studies have indicated, in terms of thinking about intersex people or people who have differences of sex development, because not all people have differences of sex development and identify as intersex, that regardless, about 1 out of 1,500 to 1 out of 2,000 children are recognized at birth to have a reproductive or sexual anatomy that doesn't seem to fit typical definitions of maleness or femaleness. And it's notable that this is the same percentage of the population who are redheads. So we're going to go next through a very rapid fire overview of sexual and gender minority population health disparities. So as we'll go into in more depth later in the course, that Williams Institute has documented that sexual and gender minority individuals experience higher rates of poverty than their cisgender heterosexual peers, although there is considerable variation of this within sexual and gender minority subpopulations, as you can see here, that equal percentages of cisgender bisexual women and transgender adults reported high levels of poverty. And you can see this on the far right side, the highest levels of poverty of those detected within the study by SGM subgroups. And also even in comparison to cisgender and straight counterparts. So here we have cisgender straight men, and here's cisgender straight women. Interestingly, cisgender gay men reported the lowest levels of poverty within this study. You can next, this is a breakdown looking by sexual orientation, gender identity subgroups, and race. And what you see is high rates of poverty, in particular among Black and Hispanic individuals and other race individuals compared to white individuals across these categories. We went through this earlier about the breakdown of economic status, a bit of non-binary LGBTQ people. It's important to note that there are extremely high levels of sexual and relationship violence within LGBTQ communities. And of course, these numbers are extremely high in the general society as well. But among adult females, according to the CDC's NSBIS surveillance system, 43.8% of lesbians, 61.1% of bisexuals, and 35% of heterosexuals reported rape, physical violence, and/or stalking. Comparable numbers among adult males within that survey was 26% of gay, 37.3% of bisexual, and 29% of heterosexuals. 55% of non-binary LGBTQ adults reported physical or sexual assault, according to TransPop, a survey that is got a nationally representative sample of transgender people. And then 47% of transgender adults report being sexually assaulted in their lifetimes within the 2015 US Transgender Survey. So these are really tough numbers to read, but I wanted to make sure that they were in this talk because high levels of violence and victimization are a key component of what might be contributing to health disparities and minority stress within SGM populations. We also see disparities among sexual minorities in terms of chronic conditions and mental health diagnoses. So what you can see here is that on the first two columns, they were looking at men, and so gay versus heterosexual men and bisexual versus heterosexual men in terms of chronic conditions and for physical health in the first 4 rows, and then for mental health in the bottom 4 rows. And you can see disparities across the board for both moderate and severe psychological distress, and same thing among lesbian versus heterosexual women and bisexual versus heterosexual women. Only lesbian versus heterosexual women didn't reach significance for the severe psychological distress, but there is significance for all other findings here. It's also notable that in general, bisexual populations appear to be having higher, greater disparities than their gay and lesbian counterparts, although all of these odds ratios are high and unacceptable in terms of indicating disparities for physical and mental health. Likewise, there are varieties of studies that have shown that there are substance use disparities by sex and sexual orientation combinations. Here I'm showing studies from the BERFIS showing disparities among impact in substance use impacting gay and bisexual men compared to heterosexual men. And we can see in the next slide similar disparities impacting lesbian and bisexual women. And we also, there have been a variety of studies that have been conducted showing diabetes disparities impacting sexual minority men and women, including some of my own studies. This is a graph that's not actually published, but it is derived from tables that are in a published paper that I had put out from the Behavioral Risk Factor Surveillance Systems 2014 year data set. And there's been other studies that would support that there are diabetes disparities impacting these populations. And so the Nurses Health 2 study found that even that there's among lesbian and bisexual women, that compared to heterosexual women, there's a higher incidence rate ratio for type 2 diabetes, and in this data set, but when you adjust for BMI, that this disparity disappears. And the BMI is not the only thing you can see, the other confounders that are adjusted for. And so it's important, I think, to note that this study found a significant disparity, especially within younger sexual minority population ages of lesbian and bisexual women. By the time you get to 70, 80 years old, the disparity doesn't exist any longer. But it's notable that having disparities for something like diabetes younger in the life course would have a profound effect on having premature disability and perhaps disability that might be affecting ability to work, et cetera, earlier in life. And on that note, there's another paper that I'm showing here that looked at, they constructed categories by sexual orientation, race, and sex. And then they looked at functional limitation, and you can see that bisexual white females and non-white females report the highest percentages of functional limitation of all of the sexual orientation, race, sex categories within the data set. And straight white males and straight non-white males report the lowest. When you look within transgender populations, you can see that bisexual and pansexual transgender people are most likely to report having a disability compared to transgender people of other sexual orientations, including gay and lesbian and heterosexual and straight transgender people. And the CDC had put out some data from BRFIS again, that sexual minorities have a higher burden of COVID-19 risk factors than their heterosexual counterparts. You can look through these numbers here in the citations below. And then there have been a variety and growing number of studies showing higher chronic disease burden among transgender adults compared to cisgender adults. It's also important to note that a lot of these studies that I'm talking about really focus on gender identity and sexual identity, and they don't focus on attraction or behavior. And it's worth mentioning that because depending on what the measure is, the population that you identify that would be sexual minority or gender minority may vary considerably. And there are very few studies that would allow us to understand the variation that we might see depending on what dimension of SOGI is being measured in a study. And this is notable because there are, as I said, there are studies that have done this in the rare data sets that do have more than one dimension of SOGI measured. And they do find differential disparities on the basis of attraction and behavior and or identity. And some of my own work has also found variation between gender identity and gender expression. I have some work that is pending with Dr. Sari Reisner within the YRBS that is looking at some of these ways of measuring sleep, in particular in that paper. And so just more people making the point in their work to include Dr. Bethany Everett, looking at, of course, it's going to be important to look at sexual identity and sexual behavior when you're thinking about sexually transmitted infections. And so Dr. Everett reports here a variety of patterns of STI risk behaviors and diagnoses in this paper that's cited below. And then just a little bit of my own work. I'm trying to add to the field of SGM population health equity and health disparities work with an R01 I have within the cardiac cohort, which is a cardiovascular study, also partnering with Dr. Tonya Poti and Dr. Krista Pereira, who have a parallel R01 in the Hispanic community cohort study studying Latinos to understand, in particular, how behavioral and clinical cardiovascular disease risk factors vary by sexual and gender minority status over the life course. Within sexual and gender minority participants, we're looking at how stigma and resilience promoting factors at multiple levels associate with behavioral and clinical cardiovascular disease risk factors. And we are assessing the influence of structural stigma on these risk factors. And we're doing this both in each of our studies alone, and we're pooling our data as well to understand, because by pooling our data, we can look at this not only by sexual orientation and gender identity, but the intersections of race, ethnicity, and socioeconomic status. And we can do this in a way where we've also included measures, like I said, of stigma and resilience promoting factors, so we can see not how only the identity that is tied to sexual orientation or gender identity would it be affecting, be tied to the health outcomes within these populations, but we can also see how there might be pathways that are affecting health that are tied to stigma and resilience that aligns more with the theories that we're talking about in some of the other lectures this week. So with that, I thank you for your attention, and I look forward to getting to meet you in class soon and wish you a good evening. Thank you.